is, this is all kinds of weird that's going on. My first time for having it in the office. So is this page, right? This is your long form or your long page that I gave you. On one side, you should have your general interventions. And then at the top, you should have your exemplars, hepatitis, pancreatitis, PUD, cholecystitis, cholelithiasis, and then IBD with Crohn's and ulcerative colitis. Are y'all having problems hearing me with, do you hear that other stuff going on next door?
No, we can hear you fine.
Good. Okay.
Can you show that paper one more time? I didn't get the whole thing.
Well, all it is the general interventions are going to go in one column, you know, that we'll use across the board. And then your, excuse me, your exemplars, hepatitis, pancreatitis, PUD, the cholecystitis, cholelithiasis, the gallstones, right? And then IBD with Crohn's and ulcerative colitis. All right, so hang on. All right. So some common interventions or general interventions as well as assessments. Okay. What is the first thing you do when you go into a patient's room?
You introduce yourself.
Yourself?
Okay. That doesn't warrant follow-up or anything. We're looking for assessment cues. And so, which is information or something along that lines, whether it be history of the patient or that kind of thing.
Do you determine what the chief complaint is and then proceed with a assessment, a focused assessment?
Okay, but what is the first thing you do when you go into a patient's room? What do
Wash your hands and put gloves on.
You're not going to assess your hand washing.
You look at
Assess
the
the patient. Look at them and see what's going on with them.
What is the first thing you do? Yeah, you're going to look at the patient.
Determine two forms of identification.
That doesn't warrant, that's not a, that's an assessment of just looking at the patient, making sure they are who they are, but it's not, what do you do every morning? The first thing you do, what are you bringing in with you when you first see the patient usually? The vital signs machine, right? Vital signs, hello.
Oh.
Okay, so you're bringing in the vital signs machine, you're introducing yourself, acknowledging the people in the room, you know, you're hand washing or putting on gloves or whatever you're doing while you're, you know, explaining why you're there and everything. But vital signs are assessment, okay? You may have a tech or an assistant take those vital signs and give them parameters for what you need them to report back. But the thing is that not everybody is going to be within those parameters normally. So, but you need to know, you know, on a general basis, what to have them report, but you need to look at those vital signs quickly to determine where your patient is baseline for that day. And then, of course, you will have earlier trended your vital signs so that you know what's normal for your patient: heart rate, respiratory rate, systolic blood pressure, and diastolic. Okay, so vital signs, we take those depending on what unit we're on in the facility. We take them every hour, every 15 minutes, every 4 hours, or every 8 hours. And then again, how often besides that? PRN, right? Because if they're having something, oh, I feel hot, you go and get what?
Take your vitals.
The thermometer. Okay. Now, PowerPoint was just to help you guide. All the PowerPoint says is question, assessment, actual problems, goals, all that kind of definition, assessment, lab data and stuff. And we're going to be working through all that with each exemplar. So, but the vital signs, okay, are going to be taken depending on, like I said, what's going on. And then PRN, they say they're hot. You're going to want to get the thermometer and take their temperature, correct? Okay. If there is an intervention to be done, maybe their temperature is 101. Okay. And they have an order for acetaminophen for a temperature greater than, 101 or greater. You can go get the acetaminophen and give that to them. But then what do you need to do after every intervention you do?
Take vitals again.
Reassess.
Reassess and evaluate whether that particular intervention gave you the desired outcome, didn't do much of anything, or what? There was an adverse reaction or adverse outcome that we need to kind of foresee, okay, and be ready for. Okay. The exemplars are what we talked about in the first part of inflammation last week, you guys. So anyway, so vital signs, okay, and how does that pertain to these exemplars? So we need to assess them. What else are we going to do with these exemplars specifically?
Do an abdominal assessment? Abdominal assessment?
Good, a focused abdominal assessment, right? So we're going to do all those things that we talked about, last week. And you're going to do a focused assessment initially in the morning, and you're going to do and then a physical assessment after that. But think about it. If you get your vitals done and your focused assessment, they come and get your patient for an x-ray, and you've cursory gone over, just by looking at them, they're not in distress, respirations, are within normal limits, right, for them. And then, so the abdominal, minimal abdominal pain, all that kind of stuff, they can go to x-ray. But you may have to finish your assessment, but at least you got your focused assessment where the problem is and a baseline before they go down for their test. Okay, so good. What else would you assess for? Because
look
a
at
lot of these are, I'm sorry?
I was going to say, look at labs like the CBC and the CRP.
Okay, labs are good, and I'll hold that thought for just a minute. A lot of these have to do with digestion, right? All of these exemplars and stuff in that digestive tract. So what do you think a lot of these exemplars will have
I know.
as an assessment?
I know.
Okay,
Input and output.
right.
Nutritional
Take an output
deficiency.
for hydration status. It's going to be hydration status is what we're going to assess for. And we're going to use several different things to assess that. What is the most accurate for assessing hydration status?
Weight. Or that's a
Weight.
change, I guess.
There you go.
Fluids and electrolytes.
Absolutely. Okay. Weight. And what does that mean? We just weigh the patient, or
Their previous. If they lost or gained a lot in a short amount of time, it's a problem.
okay. And so how are you going to ensure that it's accurate?
Same scale, same clothes, same time of day.
Okay, not same time of day. It's supposed to be
Okay.
when?
In the morning.
First thing in the
In the
morning,
morning.
after they void.
Okay.
Okay, but same clothes and same scale, exactly right. Exactly right. So, and usually we're weighing those patients, at least for these exemplars, daily. Okay, because we want to see how that weight is. Now, what do a lot of the units have in their beds? They're able to what? Without getting a Hoyer lift or something else.
Either a catheter or a urinal or.
You have a scale like on the
They have
bed.
a scale in the bed, right? Do you know what they use to zero out that bed? So
No.
that scale is 0 to start with,
Mm-mm.
okay? Should be one pillow and a pillowcase, a fitted sheet, whatever they use as a pad or a draw sheet, a top sheet, a blanket, and that's it, okay? The rest is patient. Now, if they've got 42 pillows, you're going to have to remove 41 of them. If they've got 54 blankets, you got to remove 53 of them. If they have one of those sequential compression devices or something that's hooked onto the bed that's machinery, you've got to get that off the bed. Okay? A Foley bag or whatever cannot be put on the bed. Okay, you can put a chair next to it and have the Foley sit on that. Make sure you've emptied it, before put a towel down and set it there, so that it's basically just what the patient is, a gown on. Those little slipper socks are not going to make a big difference with that, but having that all that other paraphernalia on that bed can make the difference of 5 pounds. Now, for assessing hydration, what kind of disease processes is that going to affect? And possibly
Kidneys.
base medications on and other interventions. What
Blood
do you-
pressure.
Kidneys,
Like fluid overload or deficit?
CHF.
Yeah. Heart failure. Okay. They gain 5 pounds in a day. That doctor is gonna, we've got to, double the diuretic right now. And we've got, they're gonna base their clinical decision making on, those kinds of cues, of assessment cues. When somebody gains 5 pounds, I know a lot of people get excited about, when they start losing weight on a new weight loss thing and they're, I just lost, 10 pounds this week. I hate to tell you, it's what?
Water.
Water weight. Okay. So when they go from one to the next day and they've, gained 5 pounds, that ain't fat. It's water weight. Okay. And those assessments need to be spot on and accurate, because that's what, clinical decision making is based on, those types of assessments. Okay. So somebody said, so weights first, daily weights, right? And then INO. INO is only as good as what?
It's accurate we are.
I'm sorry, Kelly?
It's only as good as like how accurate we take it.
There you go. Okay, especially if we're asking the patient, do you know how many cups of water you've had? Oh, hell, I don't know. And just, they filled up my pitcher this morning. You can look at it and see how much I drank, that's not going to include what's on the breakfast tray and all of that and how much they drink there. Okay. Or the output, thank God for PureWix nowadays, because, they have the measurement right there in the suction canister. So when but if your patient has a diaper and they're urinating in the diaper, what is marked on the INO?
How wet it is, or
×1. Okay, because on most adult units, they don't have what? How are you going to determine in a diaper how much?
Yeah, diapers.
the
too.
Weigh the
output?
diaper.
Okay, you got to weigh a dry diaper, and then you weigh the wet diaper, and the difference in between is the milliliters they put out in urine. Make sense? Okay, so they don't have those little scales on adult units. They have them on peds, they have them in the nursery, but they don't have them on adult units. So we usually just see ×1, meaning ×1 void. That's telling you how much, how little, not really. Okay. So those kinds of things are important to remember, that INO is only going to be as accurate as the people that record. Okay. Also, what about, what else can we assess for hydration?
Skin turgor.
fluid and electrolytes.
Skin turgor?
Yeah, but just assessment. Okay. Skin turgor.
Like mucous membranes?
There you go. Mucous membranes, the conjunctiva, how dry is it right there in the eyes, or mucous membranes in the mouth? Are they tacky? Do they look dry? Are the lips dry? All those kinds of things, okay, that denote hydration status. So what about pain? Are we going to assess for pain? How often do the institutions make us assess for pain now?
Every 2 hours or something.
Every 2 hours. And best to use the PQRST mnemonic, okay, to chart that. What else do we do for all patients? Especially the ones in the exemplar. What about turn Q2,
Yeah.
right? Turn, cough and deep breathe every 2, especially if they're a surgical patient. Okay. Or incentive spirometry to 1 hour while awake. Incentive spirometry is that little thing you use, take a deep breath, you tell them take a deep breath in as much as they can and then blow out at such a rate that they can hold this little ball within their goal, okay, for about 10 seconds. Sometimes it's 5 seconds is going to be it, but they control that exhale to keep those alveoli open. Okay, so when turn, cough, and deep breathe, we want to make sure that they're coughing. But if they've had any kind of abdominal surgery or whatever, what are we going to tell them to do that's going to help them with that pain?
Splint.
Splint with a pillow right over the abdomen, hold it tight while they cough. Okay, so excellent. And then what about head of bed?
You want that elevated.
Up to 30 degrees.
Okay, 30 degrees or more. Being flat with these types of exemplars. Okay, a lot of times they're going to be kind of bloated, if you will. They'll feel kind of bloated. Sometimes that's the edema of the organ there. And of course, a lot of these organs are up against the liver, the pancreas, they're up against the diaphragm. So when they get edematous, they push up against the diaphragm. So are they going to be comfortable lying flat?
No,
No. And they're not going to be comfortable leaning way over and compressing the stomach. So they're going to be more comfortable in a recumbent kind of position, semi-Fowler's, or 30 degrees, somewhere around there. Okay. Another thing, skincare. We got to make sure skin's intact, right? So we need to provide the skincare as well as turning them. And then we need to teach them about things, about their exemplar, the disease process, and reinforces as needed so that they don't come back with the same problem again and again. Because what did I say about the chronicity of inflammation? What does that do to cells? It changes them, right? The more exacerbations of inflammation, the more it changes those cells to be abnormal and then can predispose them to cancer. Okay, and also the more exacerbations they have and chronic inflammation, the more fibrotic those organs get, and they don't function as they should. Part of the inflammatory process, right? Okay, so first one we're going to look at is hepatitis. All right, so it's what? Inflammation of what?
The liver.
The liver.
The liver.
liver.
And it's caused by a virus, alcohol, toxins, medications, autoimmune disorders, that kind of thing, and causes damage to the cells. So for the inflammatory process, what we're going to look at are the viruses, hepatitis A through E. Okay, and you'll learn in metabolism about what alcohol does to the liver, chronic exacerbations of that, and what happens, of course, cirrhosis, and goes into liver failure and that type of thing. So, the liver is integral in the metabolism of nutrients, drugs, alcohol, toxins, and all that kind of stuff, and the bile production. Okay, so if there's a virus, though, what happens is the incubation period, there are no signs and symptoms. It's asymptomatic for incubation. Okay, and then approximately 2 weeks after exposure is that prodromal phase. This should sound familiar from infection from level 1, right? They get these non-specific flu-like symptoms, the fatigue, the malaise, they just don't feel well. They don't feel like eating, the anorexia. They may have they'll have myalgia, which is muscle pain, arthralgia, which is joint pain. Okay, and they may have some mild but chronic right upper abdominal or epigastric pain. They may have some fever. Okay, so then they have the icteric, icteric phase, which is the onset of jaundice. Okay, and that's usually 5 to 10 days after the initial symptoms. So during that prodromal, and so if they get jaundice, that means the bilirubin from the breakdown of the red blood cells is continually circulating in the bloodstream and not being excreted, right? So the bilirubin level would be going up and causing them to turn jaundice. What is that, and how do we recognize that?
Yellowing of the skin, eyes, mucous membrane.
Okay, so we may be looking at the sclera of the eyes, right? To determine presence of or initial jaundice. And then what, people of color, where would we look?
The gums and the eyes.
The palate, underneath the tongue, okay? And then eventually, but hopefully not, it would be the skin. And if you've ever seen somebody in true liver failure, they are highlighter yellow. Highlighter yellow. Okay, so if they can secrete the bilirubin, they may not get jaundice, but their urine is going to be dark, dark, dark. Okay, that's where the bilirubin is going. And then they have a convalescent period of 2 to 3 weeks after the acute illness. Signs of improvement, you know, abdominal pain is less, jaundice disappears, they feel more like eating, they have a little bit more energy. And things like hepatitis A and E are short-lived. They're only 9 to 11 weeks, you know, where they're gonna feel the disease process and stuff. They resolve in 9 to 11 weeks. So complete recovery depends on treatment and type and treatment. So when we're talking about vital signs, you know, you're going to see, like I said, possibly some fever, okay, or elevated temp. What about antipyretics? Can you just give them 650 milligrams of acetaminophen every 6
No.
hours as needed?
No,
You have to
you
watch
can't-
because the
you
liver.
can't filter it out.
Okay, good, because it's toxic to the liver. Same thing with NSAIDs. So unless it's really an elevation over 101 for just a slight elevation, or even over 100, you know, 100.4, you're going to just give them some loose, you know, make sure their clothes are not tight fitting, decrease the temperature in the room, those kinds of things to get them comfortable and get their temperature down, as opposed to really, you know, whacking them with acetaminophen or ibuprofen. Okay. Let's see, what else? So the vital signs, the assessment again, when we're talking about, you know, a nutrition problem because they're anorexic. Okay, so if they don't feel like eating 3 meals, what might we do?
6 small meals.
Okay, so 6 small meals, or maybe
Or
some
supplement.
kind of supplement, Ensure, whatever, Glucerna, you know, well, not Glucerna, just depends if they have diabetes component in there, you know, just something that's going to help them with some nutrition, but it can't be this big whopping protein drink, because what also does the liver do? Helps metabolize what?
Protein.
Protein. So you can't keep feeding this liver, okay, protein, and it not be able to break it down sufficiently. And because what can end up happening is the nitrogen component of that protein combines with the hydrogen and forms ammonia. And then the ammonia rises and causes encephalopathy or problems with level of consciousness, okay, with the liver. Usually you don't see that with hepatitis so much, but because they're usually short-lived, but sometimes with the chronicity of hepatitis B, hepatitis C, you know, you may see some of those symptoms. So you have skin integrity, which if with not being able to get rid of the bile salts or turn them into, you know, the bile and stuff, they'll actually find their way through the bloodstream and come out of through capillaries and stuff and go to the skin. Okay, and it causes itching, tremendous itching. Okay, the big thing with the skin integrity there is when they itch, what?
Keep their nails short.
Okay,
Right.
can we cut those without an order? No. Because in case you get the quick of the nail, or you know, you clip it too close or what have you, can put them at more risk for infection and things like that than you know, somebody else doing it, or the doctor says, yeah, go ahead, just be careful. Okay. Also, they can put, the family can get them white cotton gloves to put on their hands. It doesn't interfere with the fine motor and the dexterity of their fingers, but it does keep them from using the nails to get those deep scratch marks and things off of them. Also, water that's, you know, you can wipe the arms and stuff with water that's not too cold. You don't want it cool so that it raises goosebumps. That's going to cause itching. And then if it's too hot, which kind of dries out the skin, but when it's too hot, that also increases itching. So you want it just a mild temperature that helps take off the bile salts. You can use a diphenhydramine cream that will, you know, help the skin be supple. Okay, but and then take away that itching, you know, topically. Why wouldn't we want to give diphenhydramine orally in the maximum dose all day?
Processed in the liver.
What did I say about the ammonia? What does ammonia cause?
Encephalopathy.
Encephalopathy, or the level of a change in level of consciousness. So what does diphenhydramine usually, what's a side effect?
Make
Sleepiness.
Okay, so how are we going to know if that's a factor of things getting worse via blood work and that kind of thing with assessment, or that's, you know, the influence of the diphenhydramine making them sleepy? You see? So you'd have to keep that as an ongoing assessment. So hepatitis A, what do you know about it?
It's digestive symptoms usually. Doesn't it cause digestive symptoms problems?
Okay, so we talked about the pain, okay, that it can cause in the right upper quadrant, or discomfort, not a whole lot of pain usually. And then, you know, nausea, possible vomiting. So what could you give them for the nausea and vomiting?
If the doctor orders like Zofran or something.
Ondansetron, okay, an antiemetic, exactly. So Ondansetron. It's the generic for Zofran. Okay, so we can give that for the nausea. Okay, and then give them what they'd like to eat or feel like eating. Again, the smaller meals, the supplements, those kinds of things to help support their nutrition. Right? So we definitely want to decrease their pain, but we've got to avoid acetaminophen, ibuprofen, and that kind of thing that can be toxic to the liver. So it may be a little bit of an opioid, just plain, without the acetaminophen component. Okay, you know, like half a 1 milligram dilaudid pill or something of that nature. However, it's still a med that has to be broken down. So you can't throw a bunch of meds at them because the liver will not be able to metabolize them to a form that's not going to be toxic, right? So we need to talk to them about a healthy diet, and then able to verbalize protective measures against spread. So hepatitis A is spread by what?
Fecal oral route.
Fecal oral route. Very good. Okay. So what would cause us to have or to contract hepatitis A? Fecal
Eaten in the
oral
French
route.
Quarter.
Hmm?
Oh, eaten in the French Quarter.
Eating where nobody washed their hands or
Eating in the
processed it, right?
Okay, yeah, so people that are involved in food preparation that don't wash their hands, you always wondered why big sign up there that says all employees must wash their hands in the bath, you know, you see them in the bathroom before returning, you know, to the kitchen. Fecal oral route. Okay, going into a country that maybe doesn't have the sanitation and filtration that we have for water. Okay, so their water is a little contaminated. What would be an example of that?
Mexico.
Okay, that's what gives us the what? The diarrhea, right?
Right.
The trots, as they call them. Okay, so how else? What do we eat a lot of around here?
Oysters.
Okay, and what else?
Crawfish.
Seafood.
Okay, crawfish, oysters, you know, shrimp. Where do they all live?
The bottom of the
mud.
water.
Where do you think contamination goes? Settles
the
in that muck. So didn't you ever wonder when they said send out the warnings about, you know, don't eat the oysters from this part of the lake or this part, you know, they're not good, or, you know, whatever, and they just kind of, well, yeah, you get hepatitis A from them. Think about it. Oysters filter the water down from there through the shell and through their, you know, their bodies. So that virus can permeate the oyster. Shrimp and crawfish live on the bottom, and so they're constantly feeding on things from the bottom that are contaminated. And so then that can reflect, you know, upon what you get as far as the virus. Okay, so hepatitis A, how could we avoid it? Okay, hand washing, right?
There's a vaccine for it as well.
Absolutely, and it's in 2 parts. So you have 2 vaccines, you know, 2 parts, just like you have, you know, hepatitis B is 3-part vaccine, that kind of thing. So, but what does that mean as far as people that are not readily able to get health care or can afford paying for vaccines? We have to teach them what? what do we
Hand
say?
washing.
Resources,
Good hand
resources.
washing, proper
Yeah.
hand washing. Okay, the homeless, you know, usually they can walk into a restaurant or somewhere and wash their hands, you know, but they can't, you know, they don't have the funds to get the vaccines. Okay, so hepatitis A, again, hepatitis E is also contaminated food and water. Same thing, and usually short-lived and resolves itself. Okay, so let's see. What about hepatitis B?
You get it from needles or birth or
Blood
sexual
body
transmitted.
fluid, right?
Yeah.
Sharing
Mhm.
needles, sexual intercourse. So those kinds of things for hepatitis B. And then I just mentioned 3 vaccines, right, for the course of hepatitis B. We know, we're like, oh yeah, you know, that's the way it's supposed to be. You know, we get it for healthcare, right? Because we're in the healthcare field. They started giving it to babies, you know, to start that process because they recognized that that was the best place to start it and have them go through that process when they're young. Okay, and it's not detrimental. Whereas then there's the people like me that, you know, I'm in the healthcare provider business, right? So I get my hepatitis B. What about other people that aren't? Unless their healthcare provider tells them they need to get it, you know, that's not going to be very high on their priority list. Okay, so if they end up with hepatitis B, and of course, in order to have hepatitis D, as in dog, they have to have hepatitis B, but they can end up with chronic things, you know, and end up on this drug. So I just put it up there for you. Tenofovir disoproxil fumarate. Okay. And that is an antiretroviral for chronic hepatitis B. And one of the big labs that they need to have on a regular basis is they need to have a BUN and creatinine because it's excreted through the kidneys. And BUN and creatinine tell you what? Kidney function, right? Okay, especially the creatinine. BUN usually tells you hydration status. Okay, when people are dehydrated, their BUN goes up. Their creatinine might go up slightly, but unless they're having some kind of acute, you know, renal impairment or something, usually the creatinine doesn't go above 2.0. You know, it stays within that functional range unless they have kidney issues themselves. Okay, so as they rehydrate, the BUN's going to come down. Their creatinine will come down a little, you know, more to whatever their normal is, and everything's cool. Okay, so so that is for chronic hepatitis B. So hepatitis C, how do we get that?
Same way.
Okay, mostly shared needles, history of HIV or received blood products before 1987. A lot of people don't even know they have it until it rears their ugly head with, you know, those signs and symptoms, the fatigue, the flu-like symptoms, right? So let me type this in. There is, these drugs are sofosbuvir is the, like the class name, the generic class name, and they have other things like it's sofosbuvir based regimens, and those are in these two drugs, which you might have heard. Okay, so that's for hepatitis C, and those are the ones that can actually cure hepatitis C. And they're expensive, you know? So a lot of times when we're talking about hepatitis, you know, we're talking, again, liver. You can see how much fibrosis occurs with an ultrasound or a liver biopsy as to how much fibrosis is there, which directly influences the functionality of the liver. Also, if you look on your lab sheets, and I think it's on the first one, okay, under the C-reactive protein, starting with albumin, the 3.5 to 5, and then the protein, the bilirubin, the alkaline phosphatase is ALP, the aspartate aminotransferase AST, and the alanine aminotransferase ALT, you know, is liver profile. And then they also need to get a PT and a PTT, an INR. Why? Why do they need those?
A clotting factor?
Clotting factors, right? To see how clotting factors are affected because of the manufacture of prothrombin by the liver, okay? If they're at risk for bleeding. All right? So that is what you call a liver profile, and they're found on your lab sheets. So that's what one of the, or a set of the labs are going to look like, and the ranges are there on your lab sheets. Okay. So again, you know, hygiene, infectious disease will be consulted. Again, we have to teach and reinforce what? What do they have to change?
Their lifestyles?
Definitely their lifestyle to reduce risks, right? Especially if they have it or if they're at risk to have it. Hand hygiene and standard precautions are really important, you know, regarding hepatitis A, hepatitis E. Alcohol and drug use, you know, again, very important, especially IV drug use. You know, we're seeing younger and younger people with liver failure that need transplants because of IV drug use. Okay, so you want to use smaller meals, use of snacks to maintain increased calories while they heal, use of nutritional supplements. We want to make sure, again, with jaundice and that itching, skin integrity, to definitely do those things that we talked about, cleansing with the water. You've got to be careful with using soap on those areas that they find that they tend to scratch the most and that itch. Why?
Can be an irritant.
Dry it out.
Yeah, especially those chlorhexidine-based soaps, okay, will dry out the skin even more and cause itching, okay? So for the fatigue and weakness, fatigue will, you know, have do a couple activities with them, or assessment or whatever you need to do, and then they may be just too tired and with the fatigue, and you need to have them have some rest periods in between. Okay. And then, of course, the antiretrovirals, the immunizations, and lots of education for patient, family, and significant others. Okay? All right. I'm going to do pancreatitis, and I'll let you guys break for just a minute. So pancreatitis is?
Inflammation of the pancreas.
There you go. So, inflammation of the pancreas, release of pancreatic enzymes into the tissue of the pancreas instead of being pushed into the duct, down into the common bile duct, and then into the duodenum. Okay. So, what will happen is it ends up backing up into the pancreas, into the tissue of itself, and those enzymes break down what kinds of things? Come on, you guys.
Enzymes that the pancreas, they break down carbs, starch, fats, and proteins.
There you go. Very good. Okay. So if this is released into the tissue, what did I say last week about it? What released into the tissue of the pancreas, it starts to do what?
It breaks itself down.
Digest.
Autodigest. Autodigest. So what is going to be the very first intervention with that?
NPO.
Yes, very much. NPO, nothing by mouth, because anything by mouth will trigger the release of those enzymes, and then they end up, being returned right back to the organ, and it eats itself. There is no amount of pain medicine that will counteract the pain of autodigestion. You have to stop that cause, that process first, and then the opiate pain medication will help reduce the pain. Okay? So, some of that, again, they're good vital signs. They can have a fever, okay, from pancreatic abscess or whatever, or just they can have a fever from the pain. They can have increased heart rate, right? Okay. And then they have nausea and vomiting and weight loss, constipation, and steatorrhea, which is that fatty, frothy, foul-smelling stools that I told you about last week. Okay. So gallstones or cholelithiasis that obstructs the pancreatic duct can be a cause. Also, alcoholism, which causes duodenal edema and increase the pressure, causing spasms, and that is in 80% of the cases that leads to pancreatitis. It's the alcoholism and the gallstones. The others could be meds or steroids or all kinds of different things. All right. And because of where it's located, remember, you have part of it in the left and it goes behind the stomach, okay, and then peeks out between the stomach and the liver. So that's where their pain's going to be. And it's severe. It is severe. And so if they have nausea and vomiting to the point where they can't hold anything down, the Zofran's not working like it should, you're going to have to put down an NG tube and decompress the stomach, suck out all that hydrochloric acid, pepsin, all that stuff that's in their stomach to give them what? Complete What?
Bowel rest.
Yeah.
Bowel rest. Very good.
Yeah.
Bowel rest. Yes. And so bowel rest is extremely important because, again, swigging water, ice chips, just the slightest little thing causes those enzymes to be secreted. So they can have nothing by mouth. A lot of oral care and stuff, but nothing by mouth. NG tube, if they have that protracted nausea and vomiting. And then you can give the Zofran, and usually that'll help, or you may have to alternate Zofran and Phenergan. Okay. What is going to be the way they get their nutrition in?
IV.
And what is that? TPN.
TPN.
TPN, which means they're going to have they're going to need what kind of access?
IV. Oh, no, central line.
Central line.
Central line.
There you go, central line. Okay. So they'll have their pain medicine hooked in like a PCA where they can patient controlled analgesia where they can press it, but locked out. They only have a certain amount they can have, and it's better than us going in every 2 to 3 hours and giving pain medicine, because then that comes like peaks and valleys, okay? Peaks and valleys of pain. Whereas a patient-controlled analgesia, they feel they're in more control and gives a steadier rate of pain control. And they have control, so the anxiety is less, okay? So they know that when they're in pain, all they have to do is press for it. They don't have to wait for the nurse to draw it up and come to their room and all that kind of stuff. Okay?
Wait, can you say again, what is that called? When
It's called a
can,
PCA, or a
PCA.
patient-controlled analgesia. And it's opioids. Okay? So, and because they have nausea and vomiting, it may be hooked up to NG tube suction. Okay? They need what? Besides the TPN? Hydration. So how are they going to get the hydration?
Fluids.
IV fluids, right?
IV.
IV fluids. They need a daily weight to make sure we haven't we're not putting them into overload. Right? Okay. So, the labs and diagnostic tests. Diagnostic tests are going to be an ultrasound, a CT scan, or an ERCP, which is an endoscopic retrograde cholangiopancreatography. And what that's basically going to tell them, because cholangio has to do with what? Gallbladder, right? Okay. Now,
What was that abbreviation?
This is going to be outpatient if they're having a mild case, because if it's totally inflamed, they can't put a scope down there. That's when they're going to use the CT scan and the ultrasound, okay, to try and diagnose. But what else? Well, let me go back. So the blood tests are going to be serum amylase, okay, at 32, I'm typing this, you guys, so you'll get it in a minute. 70 units per liter. And then, okay, serum lipase at 14 to 280. Oops. Spelling units wrong. units per liter. Okay. So those are strictly for the pancreas. Okay. So greater than 170 of amylase, greater than 280 of lipase is going to tell you that pancreatitis is going on. What also might be of interest. Wait, go ahead.
The range for the lipase.
I can't hear you, Erica.
The range for the lipase.
What about the lipase?
The lipase. The numbers that you just said.
Is it 14 to 280?
Yes,
Okay, thank you.
that's what I have in the chat.
And can you confirm that, do you want us
With the-
to, sorry, go ahead. Go ahead. You're going first.
Somebody say something. We're running out of time here.
The sedimentation rate, would you check, would that be elevated as well for inflammation?
Oh, yeah. All of
Okay.
the ESR, the SED rate, and the CRP, these are all inflammatory processes. So if they, they're going to be definitely elevated.
Okay.
So the serum lipase is going to remain elevated for 7 to 14 days. So when the serum lipase starts to come back down to normal, you know that things are resolving. So what else may resolve or start to resolve as that you know that they're getting better?
Pain?
Good. Pain will be less. They won't hit the button or require the pain medicine. What else? Nausea and vomiting are going to be less, right? Everything that's out the box is going to be less. Now, because the liver as well as the pancreas are right there up against the diaphragm, okay? That when they have edema in those organs, it can also cause fluid buildup to the bases of the lungs. So respiratorily, you've got to be right on point with those as well. Okay. So what else are we gonna look for in the labs? Pancreatitis. We're giving them IV fluids. We're giving them TPN. How about a basic metabolic profile that encompasses the electrolytes as well as the glucose, right?
Glycemic control because they're getting CPN.
Okay, and we're going to be testing, right, Q6, the glucose via the glucometer every 6 hours because of that. Good. And then a CBC to make sure there's no infective processes going on, that it's just inflammatory and there's not an abscess or something also that's underlying that. Okay. Again, with this, we're going to do INO, level of consciousness and behavior, the TPN, NG to suction IV fluids. But for chronicity, those are all good for acute exacerbations of the disease. But to live with a chronic pancreatitis, okay, that what could happen with them? They could develop what kind of disease process?
Like malnutrition?
Diabetes.
Diabetes. What?
Diabetes?
Okay, diabetes, because the function of secretion or excretion of insulin, right, is affected. And so with the less glucose that it's manufacturing and excreting, the glucose is going to be higher. So they either need a type 2 diabetic med, or it may be to the point, if they've been on that now they need to be on insulin. Okay, to cover that. And then somebody said malnutrition, okay, because chronically, as they have all these exacerbations and it continues, those enzymes are not going to be secreted in the amounts that they need anymore. Okay, so they need to take pancreatic enzymes before meals. Now they have them enteric coated. Before we used to have to give them with an H2 receptor blocker, but now they have enteric coated. You just can't have them take it with milk. They can't have milk with that. Now, if the pancreatitis is caused by a gallstone, what is going to be the remedy for that episode of pancreatitis?
Remove the gallstone.
There you go. Remove the gallbladder. Make sure that the gallstone gets removed. Okay, and then also, what do we need to teach as well? What are the major causes of pancreatitis?
Not to drink too much.
Not to drink at all.
All right.
Okay, because even the slightest, for that fibrosis, it's not going to take much as that pancreas deteriorates for them to have an exacerbation. Okay, so you'll learn in special pops, if you haven't already, that when it comes to substance use disorders with alcohol, there are deterrents and those kinds of things, meds to help with cravings and things to help them combat, the addiction that they have to alcohol. Okay, so you guys go ahead and take a 10-minute break, and I'll see you back at 10 minutes of 12. I'm here for a couple seconds if you have any questions. Okay. I'm taking a break too. Okay, you guys, I'm back to start. So peptic ulcer disease is a break in the mucosal lining of the GI tract where it comes in contact with gastric juices, hydrochloric acid, pepsin, those kinds of things, and can be a chronic health problem, okay, or is a chronic health problem. So ulcers develop when the mucosal barrier is unable to protect the mucosa from damage. Okay. H. pylori, which is what?
Bacteria?
Yes. Okay, so an H. pylori infection is found in 70% of the patients with PUD and can spread from individual to individual, oral to oral, or fecal to oral in contaminated water. Okay, so yes, again, going to your favorite restaurant, you thought you just ate too much or whatever, you could be contracting H. pylori that's going to make these little ulcers and possibly cause you pain for a while until you get it looked at. And we'll talk about that in a sec. So NSAIDs contribute to peptic ulcer disease as well, both systemically and topically. Disrupts all the prostaglandins and stuff that are secreted to help the mucosal barrier stay intact. The ulcers can be superficial or deep, and can be chronic, could be spontaneous remissions and exacerbations. Caffeine can exacerbate the problem, doesn't cause it. Alcohol can exacerbate the problem as well, but doesn't cause it. And contrary to popular belief, dietary intake does not seem to cause peptic ulcer disease, and the role of stress, according to the book, is uncertain. Whereas, you know, I've had students come to me and say, but Miss Leaf, you know, my patient's on a PPI, a proton pump inhibitor, and they don't have a history of GERD or PUD. So why would they be getting a PPI?
Is that kind of like a prophylactic just because they're taking so many medications?
Prophylactically, yeah, due to a lot of stress that occurs in the hospital itself, the facility. If they've been on a vent, you know, the stress of a diagnosis, because if you're very stressed out, you have increased anxiety. What might that cause? An increase in secretion of acid, right? Hydrochloric acid and stuff. And so if they're NPO or if they're, you know, on a restricted kind of diet too, where they can't have something for that acid to act on, we need to decrease that acid so it does not cause a problem. So very good. And actually, if you're a smoker, it doubles the risk that you will have PUD. So also the use of steroids. Okay. And then we talked about NSAIDs. So abdominal pain is classic. You know, it's going to be mid-abdominal, epigastric, the gnawing, burning, aching, all that kind of stuff. Complaint of heartburn, nausea, and vomiting. One of the main complications, or two main complications, are what?
Perforation and like hemorrhage?
There you go. Very good. Okay. So perforation means that it's perforated through the stomach and emptying contents of the stomach where?
Leading to peritonitis.
Okay, into the peritoneal or abdominal cavity that's sterile, right? Causing peritonitis, which is an abrupt increase in pain, like substantially rigid board-like abdomen. Sorry. Rigid board-like abdomen and a absent bowel sounds. Okay. Can have tachycardia, diarrhea, rapid shallow respirations, and temperature will start to rise because it's an infection and it's a very aggressive infectious process. So that is, they need to have that rectified immediately. Hemorrhage is, it has come across a blood vessel and eaten through it so that, and this blood vessel is so large that it, anybody tried to drink blood just when they were younger or had some kind of weird friend that tried to do it? Our stomach doesn't like blood. It can't digest it, not real well. And so usually makes people nauseated, they throw it up, okay? So when ulcer happens that starts hemorrhaging, okay, it's either going to come up and out, vomitus, or you know, frank red blood emesis, or it's going to be low enough where it comes through the whole intestines. And I told you guys about that with the melena and gelatinous blood, that kind of thing. So last week. So when if they start vomiting blood, what is the best way to protect their airway? Because it's not like normal emesis where, you know, you have some downtime and then you throw up again. As long as that's bleeding, it's a continuous thing. So what might be the first thing that?
NG tube?
Yes, NG tube to low suction, right? And then they're going to start what?
TPN?
NPO.
No, because nutrition's not of concern right now. What's going on? They're losing.
Oh, they're losing blood. So
blood.
they would start
Volume.
like,
Right? So
yeah.
if
They
they're
start with IV fluids.
hypovolemia, so they're going to start IV fluids, right? Because what's going to happen? What's the compensatory mechanism?
You need the IV fluids to raise up some isotonic to replace the blood volume.
Yeah, but hold that thought. What is the compensatory mechanism? What, you know, that happens
When you lose volume, your heart starts working harder, so your heart rate goes up.
heart rate goes up as blood pressure goes down, right?
Right.
And it also, then if you have that compensatory mechanism, you know you're okay. You know, the patient's okay. What happens when that heart rate starts to take a dip?
Okay.
They're going down the tubes.
Yeah.
Okay, they're going down the tubes fast and furious because the heart can't
Can't keep up.
Can't keep up. So you need to replace IV fluids, but also what else?
Electrolytes,
What are they losing?
volume,
And
Yeah, but what kind of volume?
blood,
Blood.
blood.
So if you just keep pumping IV fluids, is that going
Right.
to help? with
No.
No. So, you know, we need to be drawing a CBC to look at the
H&H.
hemoglobin and hematocrit. We need definitely a basic metabolic profile to look at the electrolytes and things, BUN and creatinine. BUN is going to tell us how dehydrated they are, and along with the electrolytes, what kind of shift there is, right? And so all those things are needed to determine how much blood that patient needs to receive to stabilize them. Okay? If you just give them IV fluids, they're going to circle the drain because no amount of IV fluids are going to help with a perfusion issue. Okay? All right. So one of the things you try and sit them up, what's going to happen? They're not going to tolerate it. They're going to get dizzy and lightheaded
The volume's not there?
because the volume is not there and they can't maintain perfusion. So you're going to have to put them down as much as needed, you know, to keep their level of consciousness. Now, if they're flat and they're out, that's not a good sign. But if they're conscious and they're flat, and you start to raise the head of the bed and they say, oh, I'm getting dizzy, you put it back down. Okay? You need to preserve those brain cells for those patients. Okay? Now, this is where, when there's a hemorrhage, this is where an EGD, the esophagogastroduodenoscopy, becomes interventional. They don't do surgeries and do gastrectomies anymore most of the time. Okay? They're going to go oral down into the stomach and they're going to clip that ulcer to stop the bleeding from the inside. Okay? And so when they do that, they irrigate and stuff to make sure that it stops bleeding. They'll do, you know, they'll look at it. It looks good. Then they'll take some serial, you know, H&H or CBCs to see where the hematocrit and hemoglobin are going. And hopefully they'll stabilize or go up, you know, with the transfusion of blood. But they need the fluids. Okay. So if they're vomiting, they're an NG tube, which means what? Are they going to be able to eat?
No,
Are you going to put them on enteral feeds?
no.
No.
So if they have to be like that for a while, okay, and you know, having trouble kind of resolving this issue, they would have to have
TPN?
TPN. And then but before you start TPN, what kind of access do you have to have?
The central line.
The line. There you go. Initiate TPN, glucose checks, right? Every 6 hours with sliding scale insulin. Okay.
So do you wait until the EGD to start the blood transfusion so we don't like waste it?
No, it all depends how the orders. I mean, if you've got a team that's already in-house and they're, you know, you're transferring that patient, is going to end up going to ICU. So you're going to do a rapid response on them and get them to ICU, and then hopefully an endoscopic team can, you know, meet the patient there, or, you know, be there within enough time, you know, and be able to then, not enough time, but I mean, get there within a short amount of time to be able to clamp that or clip that EGD closed. I mean, that ulcer closed with that EGD. Now, because of the clipping of that closed of that ulcer, they may feel some pain. So they may give them a little opioid analgesia. Okay, but they're not going to continue on opioid analgesia. Why?
Level of consciousness and stuff.
No. What is opioid?
Transpiration.
Constipation. Okay. How are you going to know, you know, if constipation or slow motility, should I say, happens because of the opioid or because something else is going on? Okay. So besides, what's really happening there is the hydrochloric acid, right? And the pepsin getting into that ulcerative area. So they're going to put them on IV pantoprazole, which is Protonix, to keep that acid production to a minimum. And then eventually, okay, what they'll do when they're able to remove the NG tube, when the bleeding stops, they'll give them sucralfate, okay, or bismuth, which helps coat the stomach. okay, and allows that mucosa to heal, which is what's needed, okay, for them to do, okay? For peritonitis, because that happens to be an infection, what do you need to hang in addition?
Antibiotic.
Antibiotic, absolutely. So IV fluids, and then the antibiotic needs to go up to keep them from going into septic shock. Okay. So usually though, these ulcers, unless they turn into bleeding, if they're a chronic thing, they will have the EGD outpatient. Okay. When they come in to have the procedure, the reason why they pick the EGD and not something else is because it gives them the most information in one test that is, yes, it's invasive, but it's minimally invasive and can give them more things where they're eventually probably going to end up doing an EGD to begin with, but now, you've racked up all these charges on the insurance company with all these other tests. So the EGD, when they put it down, they're going to look at the esophagus for redness, erosion, swelling. They'll go down into the stomach and they can visualize, the ulcers. And these GI doctors can tell the difference between non-steroidal anti-inflammatory or just steroid ulcer that forms because of those drugs, and H. pylori ulcer as well. So because they're right there, they can take biopsies just to confirm what they already know by visualization. But they can also see the depth of the ulcer. They can see all those different kinds of things. So the H. pylori, they're going to treat with either a triple or quadruple therapy. They're going to have 2 different kinds of antibiotics. And then they're going to have a PPI, proton pump inhibitor, the aprazoles. And then with that's going to be the triple. The quadruple therapy is going to include bismuth, like Pepto-Bismol, okay? And will cause a darkening of the stool, but it's going to protect that mucosal layer and so that it can heal properly, okay? So whenever you have tests that are going to be outpatient, that patient needs to come in and their vital signs have to be within normal limits, okay? Because if they're running a fever going in, they're not going to do it because they can't then discern, well, they came in with a fever, now they have a higher fever after the procedure. Is that due to the procedure or just because they had a fever to begin with and it was on the rise? You see what I'm saying? So we can't assess for complications if they come in, already compromised. All right. So we're going to take care of the pain with the bismuth and the PPIs and things, deficient fluid with the IV, as well as bleeding, imbalanced nutrition. They're going to find what foods irritate their stomach and then what foods, don't make a difference. So you can't tell them, oh, no spicy foods, no this, no that. It depends on how they are. Now, there's some foods that will readily, interact, like alcohol. Never put alcohol on a cut. Doesn't feel good, does it? Okay. So there you go. We need to teach relaxation, stress reduction, and lifestyle management techniques, right? Excuse me. facilitate adequate rest, balanced nutrition, diet restriction is not needed. Moving on to gallbladder. Okay, cholecystitis, inflammation of the gallbladder, cholelithiasis, inflammation of the gallbladder due to gallstones. Okay, gallstones are usually made up of cholesterol, and it's characterized by right upper gastric pain. They usually have the chronic condition, and they don't realize what it is, the patients, until they have, this one time where all of a sudden it's either infected or there's a stone that blocks or what have you, and causes them great pain. They start throwing up like nobody's business, and they're running a temp. Okay. How they diagnose that is with an ultrasound. Okay. And the vital sign abnormality will definitely, the fever, the increased heart rate, usually a little bit increased systolic, is going to be because of the pain associated with it. They'll have nausea and vomiting, for which you can give the ondansetron or Zofran IV push. Okay. Let's see. And because if it's cholelithiasis, what other things might be affected? What other organs?
Pancreas.
And what else?
Liver.
Liver. Good. Right? Because they all come into the common bile duct. Okay. And so if there's a gallstone that comes and blocks that, you will see, if they're, when they're admitted and stuff, you will see, like jaundice come overnight because it blocks, it blocks the bilirubin from being able to be excreted in the way that it's supposed to. And so you end up with those patients that have the yellowness, right? What happens? What's the first thing, number one intervention when they come into the hospital with the exacerbation of cholecystitis?
Also NPO?
Tell me.
NPO.
NPO, yes, absolutely. Okay, so NPO is the first thing. Why?
Because the pain is coming from the blocked bile, right? So if you're eating, then you're triggering it to be released, but it can't be released until there's more pain.
Yeah, but what intervention are we probably going to use?
Bowel rest.
Not really. What is a common Yes, Alexis, surgery, right? Do we need that gallbladder?
Nope.
It's a storage container. Okay, we just take out the storage container. Okay, so if for some reason they can't have surgery, the patient can't have surgery for whatever, okay, they would put that patient on cholestyramine, which binds with the cholesterol so that it can be excreted. If they already, and that's long term, they have to be on it every day. If they have gallstones already that have formed, okay, did anybody read what would be the possible intervention to help get rid of those?
To get rid of the gallstones without surgery, I mean?
It's like a T-tube.
What, Alessandro?
It was called a T-tube.
Okay, not, well, it could be a T2, but that involves surgery as
Mm.
well.
The
Yeah.
oral dissolution therapy?
What about lithotripsy? Have you heard of lithotripsy? It's a concentrated ultrasonic wave that it goes into a certain area, the gallbladder, and maybe down into the duct somewhat, to pulverize what stones are in there to a very small amount so that they can be excreted.
And how is the lithotripsy administered?
It's an ultrasonic wave. It's just,
Oh.
it's a procedure, so it's external. Okay, so it's not like a surgical procedure, although they have to go through some of the same blood tests and those kinds of things. But, and then, you know, it, like I said, pulverizes those stones and helps them excrete. And then by them taking the cholestyramine, the rest of that, or the cholesterol that then goes into there, will be bound with that and excreted, and hopefully no more stones will form. Okay, so again, you know, diagnostic test again is the ultrasound. They put the ultrasound down there, look at the gallbladder. If there's a thickening of the wall, a narrowing of the duct, they can see sludge, they can see stones, whatever. They're like, okay, take it out, prep them for surgery. So nausea and vomiting, they'll get Zofran. You'll make sure they have IV fluids going. If they have a fever, probably give them antibiotics before they actually go into surgery. What kind of surgery are they going to do?
Cholecystectomy.
Yeah, cholecystectomy. What kind do you think?
Laparoscopic?
Yes, that is the preferred method nowadays, to have a laparoscopic cholecystectomy. It's 4 little incisions, okay, that they use. You know, they use a scope. They use, you know, little clips and stuff and retractors and different things to be able to get in there. How do you think they visualize that gallbladder? What do they have to do?
Is a camera in it?
Yeah, there's the scope, but they have to inflate that peritoneal cavity with gas. Okay, so you're going to be blown up so that they can visualize, you know, with just a little bit of movement, the gallbladder, to be able to take it out. Okay, and so at the end, when they're tying things off and get ready to remove, you know, those that hardware and stuff from doing the surgery, they're gonna try and get as much gas out as possible. A lot of times that doesn't happen real well, so a little gas is left. So what your patients might experience is shoulder pain because of the pressure of the phrenic nerve, and along the diaphragm has referred pain up to the shoulder. So you're going to have them change position frequently. And as soon as they can get up and ambulate, that's what they're going to have to do to mobilize this gas and be able to then have it reabsorbed so that it can be, you know, excreted. Okay. So, different labs associated. So if the liver's involved, or how can we tell if the liver's involved?
Serum bilirubin test?
Okay, the liver function test or liver profile we talked about with hepatitis. What other organ might be involved?
Pancreas.
Okay, good. So we need the amylase, lipase. For both of those as well, we're going to need basic metabolic profile, right? That includes BUN, creatinine, and all that kind of good stuff. CBC, to see if there is an infective process going on for which they have to hang antibiotics. Okay, and then nutrition. They're going to have to change their lifestyle because they have to. It doesn't have to be real low fat, but it's got to be lower fat than what they've been eating that triggered the gallbladder, right? Because if they have a real fatty meal, the liver's gonna not be happy and it's gonna colic like that gallbladder did and cause that pain. So the liver will tell that patient what they can and cannot eat as far as being on a low fat diet. I ended up having a cholecystectomy, but I started having symptoms a year ago in September, and I was able to last all the way till February to be able to, by changing my diet to almost no fat, and then after that, low fat. But guess what? I can't eat any bacon, like not one strip, because my liver colics with that. It's like, nope, got a secrete bile, not happy. If you want to feel like this, keep eating the bacon. Otherwise, ain't no way. So, again, vital signs are important. Turn, cough, and deep breathe. Emily, get up to mute.
You can't see it.
So, turn, cough, deep breathe, or incentive spirometry. Promote effective pain management, so they will have opioids, but not for that long, thanks to the opioid crisis. When a doctor writes a prescription for pain medicine, it's definitely that. And then balanced nutrition, all those kinds of stuff. And then again, the surgery. Now I will do inflammatory bowel disease on the board as well in 510. And this usually happens to me with this last part because there are so many functions of so many organs in inflammation that it's hard to make sure that everything gets covered with with what we need to do. So I will post it, and I'm going to do the board thing, this Cast-O-Matic, but I will also upload, either this or the ones from tomorrow, just the Zoom link, and get that processed for you. And then I'll do the first week as well, in case you want to run through all of it. All right? You guys have a good day. Take care. And don't worry about a thing. I'm the one that writes the questions and everything. So you will have the information you need to do well on the test.